Usually when we talk about a medical diagnosis, there's this expectation of like absolute precision.
Oh, sure, yeah, people want certainty.
Right. Think about breaking your arm. You look at the x-ray, you see that jagged white line, and the doctor just points and says, there it is.
Exactly, it's binary.
Yeah, broken or not broken, you know exactly what has to be done to fix it, and you, as the patient, are just kind of along for the ride.
And that binary nature is comforting. I mean, we like our medicine to be visible, highly categorized and neatly resolved.
But step into the world of pelvic health and post-surgical recovery, and suddenly that pristine x-ray machine is, well, completely useless.
Totally useless, yeah.
The diagnostic and treatment landscape here is murky, it's highly individualized, and just incredibly complex. So, welcome to another deep dive.
Glad to be here.
Today we're tackling a highly sensitive, but honestly critically important medical question that affects so many people, but is rarely discussed openly.
Right, it's a topic that really stays in the shadows.
Yeah. Our mission is to figure out, can over-tightening after pelvic surgery or radiation actually be treated?
Which is, it is the absolute definition of diagnostic muddy waters.
Yeah.
But to answer the question right up front, yes, it actually can be treated.
Oh, wow. Okay. That's good news.
It is, but getting there requires understanding an entirely different side of human biology.
Okay, let's unpack this. We've pulled together a really fascinating stack of medical guidelines for you today, diving into protocols from the NHS, the Cleveland Clinic,
Some really heavy hitters.
right, and the National Institute for Health and Care Excellence, which we'll refer to as NICE, plus some highly specialized clinical reviews.
Yeah, and right at the center of all these documents is this really profound irony.
Yeah, I noticed that too. You have these complex pelvic procedures, right? Like repairing severe tears after childbirth, treating pelvic organ prolapse.
Or even performing reconstructive surgeries, yeah.
Exactly. And their entire purpose is to restore function, to give the patient their comfort back, yet sometimes the body responds by overhealing. It creates this incredibly painful over-tightening instead.
And that concept of overhealing is exactly the biological mechanism at play here. Because, well, the human body does not actually care about your long-term comfort.
Really?
No, or your sexual function. Its primary directive, honed over millions of years of evolution, is literally just to close a wound and prevent fatal infection.
So it's just in pure survival mode.
Exactly. To seal a breach quickly, the body just rushes in and lays down scar tissue. But scar tissue isn't a perfect replica of what was lost,
Right, it's like a patch.
It's a biological patch job. It lacks the complex elasticity, the suppleness, and the rich blood flow of normal, healthy tissue.
Which means before we can even talk about how doctors treat this tightening, which is clinically known as vaginal stenosis, right?
Right, or iatrogenic constriction when the medical treatment itself causes it.
Yeah, we need to understand how we actually get to that point. Because looking at the clinical data, surgery is obviously a massive trigger.
Oh, absolutely.
We're talking about posterior vaginal wall repairs, perineoplasties, where they, reconstruct the muscular area between the vagina and the anus.
Right, and gender-affirming vaginoplasties as well.
Yeah.
Basically, whenever a scalpel enters a highly dynamic, sensitive area, trauma is introduced. The body detects a crisis.
And it freaks out.
Pretty much. But surgery is only one part of the equation here. One of the most significant triggers for severe stenosis outlined in these guidelines is actually pelvic radiotherapy.
Used for cancer treatments.
Yes.
I want to dig into that because the NHS guidelines detail it heavily. So, radiation doesn't involve a scalpel, obviously.
No, it doesn't.
How exactly does an invisible beam of energy cause physical tissue to shrink and tighten up like that?
Well, what's fascinating here is the cellular cascade. You see, radiation therapies are designed to destroy cancer cells by damaging their DNA.
Okay, that makes sense.
But collateral damage is unavoidable. The radiation alters the mucosa, which is that delicate, moisture-rich inner lining of the tissues.
Oh, so it just fries the delicate stuff.
Essentially, yeah. First, you get this acute inflammatory phase. For a few weeks, the tissue is red, swollen, actively inflamed.
Sounds incredibly painful.
It is. But as that acute phase burns out, the body replaces the damaged mucosa with fibrosis.
Wait, so fibrosis is basically that overhealing we talked about earlier.
Precisely. Fibrosis is this aggressive, dense network of rigid proteins. It turns flexible tissue into something thick and unyielding.
Wow.
And to make matters worse, this doesn't just happen in a vacuum. You often have compounding factors.
Like what?
Take menopause, for example. The natural loss of estrogen already causes pelvic tissues to thin out and lose their stretch.
Ah, I see. So you add in dermatological conditions like lichen sclerosis, which already weaken the tissue structure, and you basically have a perfect storm.
That's a completely perfect storm, yeah.
And the symptoms resulting from this fibrosis are just devastating. I mean, the sources say patients experience severe dyspareunia, which is that excruciating pain during sex.
Right.
There's an inability to use tampons, frequent instances of tearing and bleeding,
Yeah, the tearing is very common.
and agonizing pain during routine pelvic exams when a doctor just tries to use a basic speculum.
It traps the patient in this vicious neurological cycle because the pain from the rigid tissue makes the pelvic floor muscles clench involuntarily.
Like a defense mechanism.
Exactly, it's a reflex. But that clenching causes more friction and pain, which creates more microtrauma, leading to even more scar tissue.
So it's almost like putting a cast on a broken arm, right? The bone heals, but the joint completely seizes up because the tissue loses all its flexibility.
That is a perfect analogy, actually.
So if a patient undergoes a perineoplasty to fix a widened opening after, say, a traumatic childbirth, how common is it that the surgeon just overcorrects, like stitches it too tight?
It's a valid question.
Or is it purely the body's unpredictable scarring process taking over?
Well, what's fascinating here is that while iatrogenic, surgeon-caused over-tightening definitely happens, and surgeons have to be incredibly meticulous, it's very often the patient's own aggressive scar formation.
Really? So it's not always a surgical error?
No, not at all. Or, just as commonly, a lack of post-operative rehabilitation.
Interesting.
If those tissues aren't actively trained to heal in a flexible state, their default mechanism is just to shrink and contract.
Okay. And that biological reality basically dictates the first line of defense then.
Exactly.
Because when you read through the protocols from the NHS and these specialized clinics, the foundational treatment isn't some high-tech laser or an experimental drug.
No, it's very low-tech.
Right. Since the issue is physical constriction, the core treatment is mechanical stretching. You literally have to break down that stubborn scar tissue manually.
Yeah, you are relying on a biological process called mechanotransduction.
Mechanotransduction.
Right, when you physically stretch a cell, it actually changes its gene expression.
Wait, really? It changes the genes?
Yeah, you're forcing the tissue to stop making rigid scar proteins and start organizing its fibers to accommodate movement.
That is wild.
It is, and that introduces the concept of vaginal dilators, or trainers.
Right, the dilators. These are, based on the sources, they're smooth, tampon-shaped cylinders.
Usually made of plastic or medical-grade silicone.
Yeah, and they come in sets of graduating sizes. But it's the timing of this that really surprised me.
The timing is critical.
Yeah, the Royal Berkshire NHS guidelines state that post-radiotherapy patients need to start using these dilators just 2 to 3 weeks after their radiation ends.
Timing is the difference between success and failure here. You have to wait just long enough for that acute burning inflammation to settle down so the patient can actually tolerate it.
Okay, that makes sense.
But if you wait too long, say a couple of months, that rigid fibrosis is already set like concrete.
Wow. And the regimen is intense. It requires 5 minutes of gentle circular and in and out motion, starting with the smallest size and slowly working up.
Yeah, and that's just the baseline regimen.
Right, because depending on the surgery, that baseline looks like a walk in the park compared to what some patients face.
Oh, absolutely.
One of the clinical reviews looking at trans women following intestinal or penile inversion vaginoplasty outlines a really grueling schedule.
It's a huge commitment.
Because dilation prevents the skin graft from contracting, right? It can take up to 2.5 hours a day initially.
Yes, and it remains a lifelong commitment to maintain patency, meaning keeping the canal open.
And along with copious amounts of water-based lubricants, they highly emphasize pelvic floor physiotherapy too.
That physiotherapy is crucial because you can't just forcefully push through the pain.
Right.
The physiotherapist helps the patient consciously map their pelvic floor so they can learn to relax those hypersensitive muscles on command.
I really want to push back on this for a second, though, because think about what we're asking of the patient here.
That's a lot.
It's a ton. For anyone listening who has recovered from cancer or major reconstructive surgery, your body is completely exhausted.
Sure.
Being told that you now have a painful part-time job of mechanical dilation just to retain your basic anatomy, I mean, that sounds completely overwhelming. How do doctors ensure patients actually stick to this?
You're right. It is a monumental physical and psychological ask. But the medical community is finally acknowledging that heavy burden.
That's good.
Clinics are building holistic care models now They recommend dedicated mindfulness techniques to manage the anxiety that makes the pelvic floor muscles clench in the first place.
Oh, so treating the mind to treat the muscle?
Exactly.
Yeah.
And they'll often prescribe lidocaine, which is a numbing ointment, for the first 2 weeks of dilation just to break that immediate pain cycle and let the brain know it's safe.
So you really have to, like, hack the nervous system. You have to convince the brain that this area of the body is safe to interact with again before the physical stretching can even work.
Precisely. The brain and the pelvic floor are intimately connected. But, even with perfect compliance and mental resilience, mechanical stretching sometimes just hits a biological ceiling,
The body just says no more.
basically. The
Mm.
tissues themselves are often so starved of blood flow and nutrients from the previous trauma that they just don't have the biological building blocks to regain their suppleness.
Which brings us to the next tier of treatment. Mechanical stretching is vital, but sometimes the tissues need biological help, bringing us to medical and technological boosts.
Right, when physical stretching hits that wall.
First up is hormone replacement therapy, or HRT. But to be clear, we aren't talking about systemic pills that affect your whole body.
No, this is highly localized.
Yeah.
We're talking about localized estrogen creams, or prasterone.
Prasterone, which is a synthetic steroid, right?
Yes. When tissues are damaged by radiation or deprived of hormones during menopause, the cellular walls become incredibly thin and dry.
Like paper.
Exactly. Applying localized estrogen basically signals the cells to hold on to water again. It plumps the tissue back up, dramatically improving moisture and restoring some elasticity.
So it essentially gives the mechanical dilators a healthier, more resilient foundation to work with.
That's exactly it.
Then the sources get into some newer regenerative therapies like PRP, platelet-rich plasma.
This is a really interesting area.
Yeah, I've heard of people getting PRP for knee injuries or like hair loss, but applying it to severe pelvic scarring is fascinating.
It is.
They draw your own blood, spin it in a centrifuge to isolate the growth factors, and inject it directly into the constricted scar tissue. How does that actually break down a scar?
Well, it comes down to what platelets actually do. We usually think of them as the things that make our blood clot.
Right, like scabs.
Yeah, but they're also tiny cargo ships packed with growth factors. When you inject concentrated platelets into rigid scar tissue, those growth factors initiate a process called angiogenesis.
Angiogenesis, meaning new blood vessels.
Exactly, the creation of new blood vessels. They recruit new cells called fibroblasts to the area, but instead of telling them to build rigid fibrosis, they instruct them to lay down healthy, bouncy collagen and elastin.
Wow.
It literally regenerates the area, bringing life and blood flow back into a dead zone.
That's incredible. And for patients looking for, non-needle options, the medical guidelines also explore energy-based devices, specifically radiofrequency and CO2 lasers.
Right, energy devices.
The core concept is that they heat the deep layers of the tissue to stimulate collagen production, but this technology comes with a massive warning label in the sources.
A very necessary warning label.
Yeah. There is a case study highlighted in the NICE overview that completely stopped me in my tracks.
Oh, you're referring to the 68-year-old patient.
Yes. This 68-year-old woman was experiencing persistent pain and tightness, so she went in for 3 courses of this laser treatment, expecting rejuvenation, right?
Right.
But instead, she developed severe vaginal dryness, burning, and worsening pain. And when doctors examined her, they found a crescent-shaped fibrous band right in the mid-vagina.
A complete backfire.
Wait, so a laser treatment meant to rejuvenate the tissue actually caused a fibrous scar band that created an obstruction. It seems like throwing more trauma at the tissue can sometimes completely backfire. I mean, she had to undergo an intense rehabilitation program with daily prasterone, moisturizers, and a home dilator program just to undo the damage the laser caused.
That case study is the perfect cautionary tale. I mean, if we look at the underlying physics of these energy-based devices, they function by intentionally causing controlled microtraumas.
Right.
A CO2 laser literally vaporizes microscopic columns of tissue to trigger a heat shock response, forcing the body to heal itself.
Ah, so it's tricking the body.
Exactly. But if a patient's immune system is already prone to overactive healing, or if the tissue is too compromised, the body just panics.
And it goes into overdrive again.
Yeah, it doesn't lay down nice, bouncy collagen. It lays down thick, defensive bands of scar tissue. It proves that these tech interventions require incredibly careful patient selection.
So, if mechanical stretching hits a ceiling, localized creams aren't enough, and lasers are either too risky or actually make the scarring worse. What is left?
Well,
When do doctors decide to fight surgery with surgery?
It is the ultimate irony in medicine, but sometimes it is the only viable option left.
Going back under the knife.
Yeah. When the scar tissue is just too thick, too rigid, and creating a physical barricade, the last resort is going back under to physically cut out the anatomical damage from the previous procedure.
And the clinical reviews outline a few specific surgical revisions depending on the anatomy of the scarring, right?
They do.
For tightness located right at the entrance, which apparently happens a lot from old episiotomies from childbirth, there is the Fenton's procedure.
Right. The Fenton's repair is highly targeted. The surgeon makes a V-shaped incision directly into the restrictive scar tissue web at the entrance.
Okay.
They physically excise that tight band, remove it, and then they reshape the perineum with dissolvable stitches. By changing the axis of the tissue, they physically widen the opening.
But if the scarring goes deeper, they move to a perineoplasty, right? Which goes beyond the skin to reconstruct the weakened perineal muscles while cutting out the scarred tissue.
Yes, that's a deeper reconstruction.
And for the most profound cases of narrowing, like severe vaginal stenosis after a gender-affirming vaginoplasty, there are highly complex revisions, such as the robotic peritoneal flap revision.
That procedure is honestly a marvel of modern surgery.
It sounds like sci-fi.
It does. The surgeon uses a robotic platform to access the deep pelvis with incredible precision. They take a flap of the peritoneum, which is the thin membrane that acts like shrink wrap around your abdominal organ,
Okay.
and they pull it down to construct a new, wider vaginal canal.
Wow.
The reason this works is that peritoneal tissue is naturally elastic, it has a rich blood supply, and it actually secretes its own lubricating fluid, making it a brilliant substitute for heavily scarred, dry tissue.
It's amazing that we can repurpose the body's own abdominal lining like that. But here is the massive catch-22, the elephant in the room that every single clinical source warns about.
The risk of restenosis.
Yes. The clinical sources explicitly warn that the risk of scarring happening all over again is incredibly high. So, logically, if surgery is what caused the scar tissue in the first place, how does a surgeon guarantee that cutting out the old scar won't just result in an even thicker, angrier scar replacing it?
The blunt reality is they can't.
They can't guarantee it.
There are absolutely no guarantees in revision surgery. The trauma of the second surgery will inevitably trigger the exact same biological alarm bells that caused the problem the first time.
So why put the patient through it?
Because this time, the post-operative environment is fundamentally different. This is why surgical intervention is never done in isolation. It is married to immediate, aggressive post-operative care.
Okay, I see.
If a patient gets a Fenton's procedure or a flap revision, they don't get to just go home and rest for 6 weeks. Rigid dilation therapy must begin almost immediately.
Wait, while the incisions are still fresh, like with stitches still in?
Yes, often within days.
Oh my God.
I know. While the cellular matrix is actively trying to knit itself back together, the patient has to introduce the dilators.
Yeah.
You are literally molding the new scar tissue as it forms.
That sounds intense.
It is. You are forcing those fresh collagen fibers to align in a longitudinal pattern that accommodates stretching, rather than a disorganized clump. You're ensuring that the wound heals open rather than closed.
Oh.
It requires immense bravery from the patient, but it is the only proven way to outsmart the body's natural urge to contract.
So what does this all mean for someone navigating this? We've covered a lot of clinical ground today in this deep dive, and if you are listening to this and dealing with these issues, the big takeaway is clear, right?
Absolutely.
Over-tightening after surgery or radiation absolutely can be treated. You are not stuck with this forever.
No, yeah.
But it is not a quick, passive fix. It requires a tiered, dedicated approach. It starts with the intense dedication of mechanical dilation to retrain the tissue, then, if needed, moving to biological aids like localized estrogen or PRP to feed the cells. And only as a very last resort do you attempt surgical revision, knowing you will have to actively mold your own healing process immediately after.
It is a demanding journey, but it is a successful one with the right clinical support. And, I think analyzing this entire treatment landscape gives us a really fascinating new lens to view medicine through.
How so?
Well, the human body is incredibly resilient, but its primary goal is to close a wound and survive, not to preserve function or comfort.
Right.
Consider how the very mechanism that saves us scar tissue can become the pathology itself.
Yeah, that's a wild paradox.
It is. It challenges us to think about medicine not just as the act of making an incision, but the far more difficult art of controlling how the body reacts long after the scalpel is put away.
The actual healing happens long after the doctor leaves the room.
Exactly. The patient becomes the primary architect of their own recovery.
That completely changes how we should look at surgical recovery. Thank you so much for joining us on this deep dive. It's a complex, heavy topic, but an incredibly important one for understanding our own physiology. So, to everyone listening, keep questioning, keep investigating, and never stop marveling at the amazing, sometimes frustrating machines that are our bodies. We'll catch you on the next one.